get it sorted. Okay. Bismillahirrahmanirrahim. I'd like to welcome you all on behalf of Institute of Advanced Endoscopy and Gastroenterology, especially our visiting faculty for this course, not a workshop. Dr. Srisha Heber from Stoke-on-Trent, UK, our very own Dr. Waqar Ahmed from Manchester, UK, and I'm sure you know Dr. Nadeem Tehami, whoever is on the active GI sites for updates and discussions. And Dr. Nadeem Tehami comes from Southampton, University Hospital, Southampton. Just a few minutes about SIAG and then about the course. SIAG in this was actually started functioning on, I think, 15th or 18th May last year. So we've just done over a year now. But our journey started way back in 2006 from 2 rooms, where we started doing ERCP fluoroscopic procedures, providing them free of cost to public sector hospitals. And so from 2006 to 2023, almost 14 years, we then moved to this unit. This is actually a 4 dedicated suites, 2 fluoroscopy rooms, 2 endoscopy suites, of which one is an EUS lab, our fluoroscopic, and then we also have ESWL. The ESWL we have is particularly useful for pancreatic stones, which is one of the major issues that we see in our practice. We are very fortunate to have a lot of support from a very dedicated anesthetic team. We have it's a team of 5 anesthetists led by Professor Safia, who used to head the anesthesia department at our university. So all our rooms have anesthesia facilities with everything. Along with that, we are supported by approximately 100 staff, which includes, from our faculty to trainees as well as trainee techs. So we have 3 aims when we started this. One was to provide service, which is completely free of cost. We go beyond what you see here when I say free of cost. We take care of everything as far as our patients are concerned. The second thing was training, which is why we are all here. And the third thing we've been working on is development of models, accessories to help learn, teach. So the second aim that we have is what you're here for, which is training. We provide, we have 3 to 4 courses a year. We used to do 2 colonoscopy, 1 ERCP, 1 EOS course every year. These courses are not like the ones that we have seen in Pakistan. We'll have some comments from Dr. Nadeem, Waqar, and Srisha. These are hands-on courses, and that's why it's very important for me to clarify here. There are 5 selected candidates from all over the country. I had nothing to do with your selection. It is Professor Sajda. I don't even know who was selected and who was not. But the idea is that we bring 5 people We dedicate 3 days, teach you as much as we have learned over the last, well, me and Vakar over the last 3 decades, and the younger people less than us, but probably better than us. So it's transmitting that knowledge, that experience, expertise to you in these 3 days. Unlike UK, which is what we are following, the model that we follow is actually what is done in UK. And Sirisha, you can add or edit anything that I've said here. We added observers because we had a lot of demand and we couldn't accommodate. So observers here learn everything that the hands-on candidates do, except that they don't get hands-on. So when we ask for comments, most of the time the observers will write saying that we should get some hands-on experience. So let me clarify here that you've just come here to observe. There is no hands-on experience for observers. But trust me, I can say for myself, in the last 6 courses that we've had in ERCP, I have myself learned a lot of things. And I'm sure everybody sitting here as an observer will learn. You will see anywhere between 20 to 25 ERCPs in the next 3 days, which will be transmitted here live. You will hear the discussion. You will have an idea of what they would do in UK if they had the same case, or what we do here. There is more than one way of doing things. So that's the background, and we've had good feedback for so far. And this is the first time that we have actually larger faculty than what we normally had. So we have 3 experts from UK. What we normally do here is we just like to hear what the experience of our hands-on candidates is, what they have come here for verbally. They were supposed to be given a form, but some mishap. So what I would like you to do, Sajda, is if you can just ask the hands-on candidates what they have, where they come from, are they doing ERCPs there, how many they have done. We just want you to tell us. You have a fluoroscopy system in your unit, you're doing ERCPs in your unit, how many have you done, what brings you here to the course, what are your aims, and so that we have an idea about where you stand in front of you. I don't know. I'll work on it.
Okay, so Dr. Abdul Malik, can you please introduce yourself, where you are from, and what your experience is as far as the ERCPs are concerned, and that's it. Yeah.
पीछे में से आकर लोगों को
सिखा रहा है आपको या आप अकेले कर रहे हैं?
नो सर अकेले कर रहे हैं एज ए टीम में और मेरे कुलीग जो हैं वो कर रहे हैं
बट आपने ट्रेनिंग कहाँ से ली?
रशिया सर लॉस
Okay, Shahri Bab.
Which setup are you from in Vishal? Hyderabad?
Yeah.
HFC. And so how many cases you done? Sorry?
And when you go back, you got training setup, you'll be training regularly.
They've got a very good setup.
Okay. Ali? Ali Khan. Dr. Ali Khan.
So I'm come from Cardiff actually in the UK. I've just been appointed as a consultant hepatologist. I've done 50 ERCP cases under training. Main objective is implement cannulation techniques to learn from more experienced people over here.
So going in the list,
So I do a training list with a consultant there, 2 training lists a week.
Gareth Thomas,
Garrett Thomas and tried is, I don't know if you know, Bob Godkin and
Godkin.
Dr. Rajesh Srivastava.
Okay, Dr. Ali Haider.
Assalamu alaikum. Thank you so much for providing the opportunity. I am from Shahid Benazir Gupta Medical University, Dhaka, Chanka Medical College, working as an associate professor in head of department. I did my supervisor in Warwick County, Professor Warwick County, Shahid Hospital, Lahore. During senior registrarship, 2.5 years, I did around about 160 cases independently, ERCP. And later on, there is a gap of around about 10 to 12 years. I never touched the ERCP scope. For last 1 year, again our department started doing ERCP procedures after getting multiple workshops from different centers in order to prevent complications. So I did completed 100 ERCP independently in my setup, but do selective cases in order to avoid complications like distal stricture, CBD stricture, small to moderate sized stones, angular periangular growth to relieve the obstruction stent. Never did my aim coming here is number one to improve escape. Whatever procedure I am doing, for example, stenting, distal stenting, stone extraction, and cannulation technique, and if never did I pre-cut if there is any problem whenever feeding the cannulation. So and the to gauge experience and knowledge and tips. Highlight stitches are left double standing in that region.
Dr. Yasin Mehta.
Assalamualaikum. मेरा नाम डॉक्टर यासिन है फ्रॉम लाहौर जिना हॉस्पिटल लाहौर and I have observed almost more than 50 cases of ERCP done independently more than 20 years. And my aim from here to be a select doctor, a continent doctor, and improve my cannulation technique, and especially I want to learn what not to do instead what to do.
So would you like to hear from?
We'll have a discussion with the observers later on. I think
Yeah.
we'll
but
just go on.
For the trainer.
train the trainer.
The training the trainer.
Yeah.
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 We need to have the
Like
train the
that.
trainer.
Okay.
Yeah, we want to have that.
I'm Dr. Masood from the International Hospital. There as a consultant gastroenterologist doing ERCP for last I think since 2005, so 18, 19 years.
है आपके पास what are regular trainings? I mean,
He has, they have a big setup. It's in the National Hospital, and he has said to them, who's a professor of the National Hospital and Medical School.
What's the answer? The answer is not it. Yeah, that's not it.
Not from Bhutan.
From Bhutan.
It's probably not here. If he was there, you would hear it.
Yeah. Okay, Dr. Azad.
I started my training in Star in 2011. Attended my very first class with Dr. Bakar, seeing him about 40 years back. And I got a chance to attend this base hospital in Hong Kong for 3 months advanced fellowship training with Dr. James Lau, Dr. Philip and I started independent classic fees, but under Dr. 2016. I sent up approximately around 500 classic fees a year at the hospital. But still in learning curve, and SAR, HOD as well there as well. My main objective is still learning plus training the trainer as well, because we have a training center as well. We have right now 3 fellowship trains there. So objective is learning plus educate the trainee as well. How to educate that is in a proper way. Yes, me.
so you said is Asim is replacing for the time being? Because you got another delegate?
Yeah, let's just.
I think he's on his way. Oh, he's on his
He's
way.
on his
Ah,
way.
He's,
Yeah, we'll wait for him.
he's on his way.
He's coming from Bhutan.
Ah,
So I think there's
Flights are a little problem because,
Yeah.
and also I think land coming, with the rain and everything. I think that's why I've given them a little bit of
sure.
So I think that should cover it all.
So three.
Yeah.
So total we have 8.
So I think what we would like to do is at the end of the course, we would come back to your objectives and see how much we've achieved or if we are close to your aspirations and objectives. So that would be the focus. And I think the likely the same would go for the TGD delegates as well.
So case-based discussion, yeah.
So we have the program there.
Yeah.
We start with the case-based discussion.
Right.
Because that's going to be, we're going to be come here and join here, and then I think separate the program.
So we'll be starting with the case-based discussion and fluoroscopic images, so if you could let us know how you guys feel about that. Let's try it out.
So it's going to be an interactive session. So we really like you guys to sort of participate and feel at ease. We really want all you to have the psychological safety. So you can say anything that you want to. There's nothing right and wrong. ERCP, there aren't black and white areas. There are lots of gray areas. And that is why I think you will find that there are some differences in approach of people who've been in the practice for years. So please feel free. There isn't
Just one.
yeah.
Anybody who's more comfortable in speaking in Urdu should not hesitate. There is no problem. This course is for you. So we all understand, and so we can respond. Keeping this medium because it's kind of generally used.
And also, bata do ki there's nothing like a stupid question. No mistakes, there's nothing, anything you can ask. So rarely get an opportunity. Team सिर्फ ERCP के बारे में एक in a room sitting and discussing, you will not get this opportunity like this. So make the best use of it. Any simple things you want, you think it's simple. How can I ask this? No, there's nothing like that. Everything you can ask.
And last but not the least, Pakistani system, professors are professors, we are we. So there is no professor. We are all colleagues. We are senior colleagues, we are junior colleagues. That's it. So you just feel free and go hटा दें उसको जो hesitation. So your own colleagues here. I was born earlier, so I'm sitting here. You were born later.
Absolutely. And I think that's what ERCP kind of stands for, ensuring really competent practice. And I think there are things that I've learned, truly it is, there are things that obviously I've learned from everybody around me, but I think the most important person in everybody's life, in my life, obviously the wife. When kids were born, the thing that I learned, one of them was that it's kind of, which I didn't know honestly, is 1 to walk and 2 to talk. And I said, what is that all about? But you realize that, you know, that what Mrs. Niaz was mentioning earlier about observers gaining more than people who are actually in it, is because people who are doing the practical cases sometimes do get this cognitive overload, that you're actually fixated on what's right in front of you and don't have an idea of actually what is happening inside the room. You as a team lead doing that case is in charge and a captain. And your job is to understand everything that's happening in the room. And it's not easy. Clearly your focus is there, the patient. And sometimes you can get distracted from it very easily. So try to feel as relaxed about things as you possibly can be. And hopefully, as Sesha said, over the course of 2-3 days, you'll learn. There are lots of areas where we actually learn from each other as well. So I think we'll start off. And if anybody wants to take a lead on it, please feel free. जैसे आपकी मर्जी हो, हम इसे शुरू कर सकते हैं. आपके setup से, हमारे setup से, wherever. You don't have to volunteer. I can start it off, but if somebody wishes to do so, then please feel free. So this is a 51-year-old female. She came to emergency department with cholangitis. Liver blood test. Now obviously you'll see some differences because obviously we have slightly different units than yours. So our understanding may not be as clear as yours, but this is somebody who's clearly not well with jaundice and cholangitis. And when you look at their blood picture, looks like they've got a bit of a mixed picture with alphos about 200, ALT about 229, raised gamma GT, and they've got raised inflammatory markers as well, so CRP is quite raised.
The thing, sorry, your bilirubin is not at jaundice level.
It's not at the jaundice level.
Well, you mentioned with jaundice and so it's not jaundice.
Okay, so
Yes,
is that 5.2?
हमारा
So this is milligram.
Oh, right.
This is what we've converted it because otherwise तो फिर मुश्किल हो जाएगा.
तो अभी तक यहाँ तक हमने इसे देखा है. एक पेशेंट आ गया आपके पास पेनफुल jaundice. कुछ चीज़ें बड़ी अहम होती हैं. If patient comes in with a painful jaundice, it's usually painless for us. And if they come with painless jaundice, it is usually painful for us. Does that make sense? So you're going to get painful के साथ आ गया तो your likelihood of getting rid of their jaundice is probably easy and you're going to get a better result out of it. Whereas if somebody comes with a painless jaundice, likely malignancy and the outcome obviously, who knows. So I think that is kind of a basic concept that you kind of have to have when you're approaching a patient. Plus, आप लोगों की practice में you see a lot of patients. You see masses coming through it. So your clinical acumen, obviously, over the period of time, becomes like this. So spot on kind of diagnosis. Somebody walks through it and says, this is what's actually happening. So this patient, obviously 51-year-old, otherwise fit well here. She comes in with cholangitis. This is kind of the blood picture. Any immediate thoughts? Any immediate thoughts?
Come on, what would you do if you see a patient like this? It doesn't matter. You do what you have to do. So you feel, I mean, she's, we don't know, just imagine we don't have this ultrasound as yet.
So even if we had the ultrasound,
Yeah.
how reliable is ultrasound in the best hands, at best? In a person like this, would you rely just on ultrasound? No. So what would your next option be? What would you do with this patient? That's what he's trying to.
आप क्या करेंगे?
अब तो हो गया यार, now medical examination, blood भी हो गया, lab भी हो गया, ultrasound भी हो गया, clinical examination में what are you going to find?
So you need to tell us what are you going to do about this patient? How are you going to manage? ये patient आपके पास आ गया, what are you going to do?
We do MRCP to see.
MRCP, okay. So if you don't have MRCP, what do you have?
I will go the path general patient having a cholangitis, and I will go for imaging CT scanning. Mr. Shiva, 51 years old. सही.
Achha, I think
If you don't have MRI available in your center, you go with CT scan.
correct. So I think एक जो अहम चीज़ would stand out from this is that we kind of in the West believe strongly that ERCP is only a therapeutic modality. However,
Let me correct it. Not only in the West.
it's here as well.
So ERCP is not a diagnostic procedure, not from
Anywhere.
It's not a diagnostic procedure anywhere in the world. It should not.
Correct. So with that mindset, so with that in your head, you've done a scan, ultrasound scan, obviously, as Professor Niall said, isn't really reliable. Obviously, it depends on many factors, machine, patient, environment, lots of other things. Obviously, you don't know what the BMI of this patient anyways is. So obviously, we thought we want to do further investigations. So patient had a MRI exam, MRCP, and that reported there were 2 small stones in a non-dilated duct. Probably won't go into detail what is the normal size of the duct or not, but this has been reported as non-dilated. एक और अहम चीज़ जो है कि I think yes, you have to rely on the information provided to you, but you should have an ability to dissect the information that's presented to you. Over a period of time, you need to have developed that eye to look at the images yourself. It is incredibly important. You will see in your lifetime, I'm sure those who've been in practice would have seen it, you do get at times report which do not actually match with what you see and what is actually the patient is presented with. So it's important to develop that side, that meniscus sign that you sometimes see in MRCP. Anyways, patient को MRI हो गया, patient jaundice है, 2 stones हैं, अब आप क्या करेंगे? हैं? You will not proceed.
What will you do if you don't proceed?
अपना rationale share करें. Why would you not?
Then is that your application with not directed
No, but he had 2 stones, the MRCP made 2 stones.
But there is an important factor here. The MRCP was done and the patients now come to you 3 days afterwards. So I'm not sure whether that's 3 days after MRCP or after the presentation, but nevertheless,
3 days after
patient now
MRCP.
3 days, and let's assume 3 days after MRCP, a patient is now asymptomatic. This is what this, and everything is getting back to normal. The CRP is okay, labs are getting better. So अब ये reason आपका बन सकता है कि you will not do something because you feel that the stones have passed, right? So would you leave this patient or what would you do? This is what we want to do. आपका patient है, आप इसको क्या करोगे? घर भेज दोगे क्या करोगे? That may be an option. I'm not saying that the other thing is, what would you do? Anybody? ERCP करोगे इस पेशेंट में?
क्योंकि इसमें तो स्टोन्स तो हैं जो MRCP हमारे पास अपने स्टोन तो मौजूद हैं। तो अब हम ये इसके LFTs भी हो जाते हैं नॉर्मल, तो बाद में तो दोबारा meningitis हो जाता है। स्टोन तो मौजूद है।
Okay, so the stone is there. Then why did the LFTs get better? There's a good reason the stone is still there.
Because stones are mostly partial obstruction, not complete.
Correct. So sometimes the stones can move up and down as well. So sometimes the stone is there. It might not be completely, it might have obstructed here, but then it would have moved up.
It has 2 options. It will either have to pass through or it will come up. So it won't be there or
आपके पास और क्या modality है इसको confirm या वो करने के लिए?
अगर आपके पास option हो, so let's put this question in a way. If you had all the modalities available to you,
सही, good.
So if you had endoscopic ultrasound अगर आपके पास है, so before ERCP, would you prefer doing an EUS? Yes.
So I think what this slide actually shows is that it is, if you just ignore these lines and look at this and if we just this included, it is a dynamic process. So any pathology that we see in our practice, pathologies are always dynamic. So you can't have a plan. When you face an enemy with a plan, the first thing that goes out of the window is plan. Okay, so plan, you have to have a plan, but also bear in mind that it's a dynamic situation and things may therefore change when you're actually there doing a procedure, because again, your job is to ensure really competent practice.
So let me take you back to the earlier part of the slide. This patient came to you with those LFTs, bilirubin of 5, SGPT of over 200, and an ultrasound showing gallstones. If you had done, in our setup, that patient would have undergone ERCP straight. And it would have been done same day, maximum next day. And we would have cleared this whole thing. So in a person who's, and this is, I'm not saying right or wrong, I'm just saying that in our setup, because we don't have 5 days or 3 days delay, MRCP is done same day. So everything is done same day. So we don't delay it. In a person like this, everything would have been done. Or even MRCP was done, MRCP would have been done immediately after ER, as soon as fasting completed, and then the next day patient would have had his or her ERCP.
Again, a lot of this depends on your facilities.
Exactly. So you have to keep this in mind that अगर आपकी ERCP में अभी 5 time लग रहा है या अभी आपको MRCP में time लग रहा है, तो then what he is trying to say, and correct me if I'm wrong, is that your plan, your initial आपकी plan था, वो that may change because you've given 3 days. You know the stone will do something, either pass or go up, and so you can't leave this patient. We all agree.
Absolutely. I think the other thing is there is very clear evidence according to the big Danish study that the sooner you do your ERCP and relieve the obstruction, the better your survival rate is. Because cholangitis in its own right has got a mortality of over 20%, which is quite high for any condition. So I think what Dr. Saad is saying, if you have the facility and you can do an emergency ERCP and symptotomy in this case, that's ideal.
Another
But you
problem,
won't have to have the
other issue that I have with such a patient is that I'm worried about them having pancreatitis. Cholangitis is okay,
Yeah.
but I don't want him to or her to have pancreatitis because then it, you start,
The whole thing changes.
the whole thing changes.
Yeah.
Absolutely.
So I think depends on your plan changes with these labs and this scenario, it's different. For the first scenario, you have more than one option. And for cost-effective treatment in a person who presents with a bilirubin of 5 with an SGPT over 200 and clearly CRP of 154, I would go in with my scope straight.
Yeah.
But if you look at the other option as well, so if you go back to the previous slide, Marie, patient is 51, what is the definitive treatment? Ultimate treatment क्या चाहिए इस patient को? All right, now. So if the patient is fit enough, so some might argue that why do an ERCP on this patient? I'll do a take a gallbladder out, flush the bile duct out, the stomach, there's a
If
stone.
the surgeon is willing to do that, I don't have a problem.
Correct. So it
Most of our
depends on
surgeons do
expertise.
spontaneous cholangitis.
After you need to know what expertise is there. If the surgeon is very, very good, and then they can go right
I can tell you majority of my surgeons with cholangitis will say, forget it, clear the duct and we'll talk about it later. If you had taken cholangitis out of here, it was a different scenario. Cholangitis changes to me everything. So
Absolutely.
for me, this would, in our system, it would classify as kind of an urgent ERCP.
But what's most important is realize that there's no one thing is always right. Your expertise, what's the expertise in your unit, how's your surgeon, what relation you have with them, it's a teamwork.
What facilities
You have,
आपके पास MRI है ही नहीं, आपके पास EUS है नहीं, so you are sitting in Larkana, but this patient or even Kuzdar, अब वहाँ से आप भेजोगे patient को लाहौर, कराची or wherever, with this, she may completely, next day the situation may be completely out, she may go into multi-organ failure.
Absolutely.
Or she may develop severe acute pancreatitis. So you have to decide according to, but also important is your expertise. What you don't want to do is, if you're not good enough in doing your procedure, is to make this patient worse and then give it to Sajda here or another surgeon or even for ERCP. So I think it's a very good.
The other thing to remember is that especially CBD stones, CT is not a very good imaging modality. It's not as good as MRCP or even ultrasound. So do not rely on CT scan.
No, but I think the answer there was that if you don't have
Yeah,
but the ultrasound said, though it turns, I mean, combine the two, maybe you get the answer. But yes, you have the MR.
Yes.
Sir, if this same patient develop, we have waited for 3 days for the ERCP, patient develop acute pancreatitis, then what will be our plan?
So this is exactly what Professor Niaz was saying, and there's a very famous statement here that small stone cause big problems.
Yes.
Okay? This is exactly what you're doing. So the two key messages, you want to be the best advocate for your patient. You want to get things done as soon as you can safely. And the second thing is obviously, small stone can cause big problems. Therefore, you have to take everything into consideration. So you've got a question. Is that okay?
Yes.
The next scenario, so just it was improved. Usually, I feel there's another possibility to go for a cholecystectomy and peroperative cholangiogram. If you find something, then you can go for ERCP.
Yeah, I think that's the most important message is that when the patient is well, don't just take a pause. आपके options देखिए क्या है. There's no urgency to do an ERCP when the patient is well. That's the bottom line. You go for a lab code, so options are different. You can do a lab code, then assess whether the stone still there, then do an ERCP. Or if you go to Sweden, Nordic countries, all their procedures, how they do it, they do a lab code. And in the patient's fit, none of them will have an ERCP outside the theater. They all do lab code, then they pass a wire down, and then they pass the sphincter over the wire, and then the ERCP is required. So it depends on your facilities and expertise.
So if you summarize the first scenario, you have further diagnostic options versus going in straight for ERCP. In my there's a surgeon sitting with cholangitis and ICRP. I think she would want the system to set. In the second scenario, there is one thing very clear. You don't want to jump into anything that is invasive straight away. You know lab colis or करनी है. So you have one surgical option, you have one diagnostic option. In diagnostic options, you have to look at what is available. Okay. In this case, patient, you can also leave and sit back because she is settling. And once everything is settled, just send them to the surgeon, get the lab coli done as soon as possible. In our practice, again, the lab coli, we don't have waiting. I mean, right, waiting means lab coli will be done the same week if we want, or practically the next
Sir,
week.
if on MRCP we don't found any stone, like I have one patient has one episode of cholangitis, young patient then developed the acute pancreatitis managed by someone other my colleague, and then again patient developed acute pancreatitis. Patient came to me, done everything but don't found any stone in the CBD.
So the scenario changes here. Supposing MRCP was done and there was no stone.
So,
Patient has clear-cut history of acute cholangitis and 2 times and gallstones also. And 2 times.
That's a good question. Okay, anybody wants to? What's going through your head? So think aloud for us. Yeah, please. So Q. That's good idea. So because you know the limitation of MRCP here, isn't it? MRCP would miss a stone which is smaller than 5 millimeter, exactly. So 4 millimeter MRCP can miss it. So I think that's a very valid point. So clearly, again depends on sort of what setting you're working with. So if you have access to it, एक और बड़ी अहम चीज़ होती है. Remember, buck should not stop with you. If you've got a facility around you where you can refer a patient, please do that. Patient comes first.
Or discuss.
Exactly.
Just pick up the phone or use the message, or there's so many now, so you're so lucky. With this, you've got all international guys sitting in.
Next case.
Yeah, it was there.
So next one, आपने से कोई anybody just take us through this case, whatever you got. So I know these are not your cases, but these are the cases obviously been encountered elsewhere. So 46-year-old man who's come in with right upper quadrant abdominal pain with D-range liver blood test. And LFTs, as you see, they are jaundiced. They have got a raised alkaline phosphatase. They've got transaminitis as well, as you would expect. And then they've done an ultrasound scan which suggested there were some gallstones and sludge. And I believe that is in the gallbladder. And then the CBD measures here around 9 millimeters. So patient has come in for ERCP. Will you do it? So,
discuss this, we discussed it, so just to reinforce the same thing. So this is actually, I put on my hand, this is my case. I did it about 8 years ago. So the patient was already in the ERCP room, right? So should I go with an ERCP from what we have discussed so far?
Yes.
Yes.
so hands up for yes.
What we just say that we need, we need some imaging, right? So that was the bottom line. For ERCP,
It is already rated and
Acha.
bilirubin is more than 4.
Okay. So on the basis that the patient has jaundice and bile duct is slightly dilated, and I thought rightly what you are saying, I went with an ERCP straight, right? Because 90% of the case, what you're thinking. But was that right? Next, if you show the next slide.
So ERCP, the duct was about 9 millimeter, cannulated with double wire technique, PD cannulated twice, sphincterotomy performed, no stone or sludge seen. And then patient obviously developed pancreatitis, amylase and CT confirmed those changes. And there was a 10 centimeter mass, intramial mass in the right iliac fossa. So patient was hospitalized for 3 weeks following ERCP and had a lap cholecystectomy 3-4 weeks later.
Now just to highlight again, the patient who don't need an ERCP will always have a difficult ERCP when you go into it. So he had a difficult procedure, we couldn't cannulate properly, and then developed pancreatitis when it was actually not needed. I think that's what we assumed, 90%. Oh, the bile duct dilated, so it must be a stone.
Dr. Yasir, I just wanted to just build up on this case. Had a similar case a couple of weeks back. A young guy, approximately, if I don't remember, he's like 38 years old, came with acute hepatitis. He was referred to me for acute hepatitis. ALT, AST 800, ALT was 600 something, and a bilirubin of 8 when he was referred. But when he came to me, the transaminases had settled down to 600, bilirubin had come down to 5, and alkaline phosphatase rose up to 800. So I thought that this is a polystatic phase of hepatitis, and as there was no stone on ultrasound. So subsequently, we planned that as these settled, and while checking for his exophyll serology, that came back negative. Now the bell started ringing, and then as the duct was dilated, so which initially I thought that because of acute hepatitis there was gallbladder edema and all everything. So I gave a repeat imaging which showed an 8 millimeter stone in the CBD. After that, the patient was stable and bilirubin came further down. It came to 2.5 and ALT AST stayed at 400 to 5. So it was planned that ERCP and cholecystectomy were to be done on in the same setting. The patient chose that he wanted one anesthesia for both the procedures. So it was a weekend, and he was sent off to on a Saturday to return on a Thursday for a surgery with similar LFT. And while he was waiting for the surgery, on Tuesday evening he developed severe pain. He came back to me with vomiting, severe pain, and all the features of acute pancreatitis. Amylase was 5,000, lipase was 3,000, and bilirubin had gone up to 6 again. So what would you do? Would you let the pancreatitis settle, or you would go in straight away because you have this is a biliary pancreatitis, and you would go in and clear the stone first?
Yeah, I think if the patient is jaundiced still, if they're cholangitis, then you can go straight to the ERCP and clear it out. But if they're not jaundiced, then you can wait for the pancreatitis to settle down.
Bilirubin was jaundiced.
It's still jaundiced.
Yeah.
So we can go ahead and.
So we went in the same night, and it was a typical ERCP, landed in the pancreatic duct. So we put in a stent, came back, and now the patient had to stay in for 7 days post ERCP, and 3 stones were retrieved from CBD.
I think one of the cats is
So what would you
hepatitis
say?
C.
I think it is a very obvious, it was a rational decision to go for ERCP with directed CBD, and although there is no any evidence of visible stone, but it is very important for and directed CBD.
No, I think there is still saying that since you're assuming that it must be stored in the CBD still, sometimes cholecystitis can itself can cause high bilirubin as well. So I think it's important to get, as we discussed, first important thing, the patient is well, no ERCP was our first message. Second message is that you need some cross-sectional imaging, either a CT or MRCP before you proceed with an ERCP. And especially, we assume just because an ultrasound slightly dilated up must be stored in the CBD, right? So I think no assumption. I think we need to get some cross-section. That's the bottom line.
I think also it depends on when the tests were done and when the ultrasound was done. So if these tests were done 3 days before the patient came for a ERCP list, then I would not do any ERCP because I don't know what the tests are for today. And the second thing is it's always, patients who develop complications, and when you review them retrospectively, you always think, am I able to justify doing an ERCP on this patient or not? If, for example, not in our setting, or if, for example, in US, where there is a high rate for going to the court and all that, would I be able to justify that this patient needed an ERCP or not? So every ERCP that I would do, I would think two things. A, would I do an ERCP on this patient if it was just my close relative because if it's indicated? And secondly, would I be able to justify? Because ERCP is a complicated procedure. You can't develop pancreatitis. You can't have anybody with zero complication rate. Everybody will have complication at some point. It's the point where you get complication that you manage the complication and you are able to justify that this patient needed an ERCP. That's why I did an ERCP and thereby having a complication.
If I can add, litigation is one way of actually persuading you or stopping you from doing, but there is another place where you have to answer. Okay, so whether you are caught in this world or not, it is very important you are able to justify what you do.
And you have
Would you justify? I think this is a very good point he's made.
Yeah.
And it's not just ERCP. Any procedure you're doing, ask yourself, would you do it? Are you good enough to do it on your family? And would you have done it if it was your family? And the answer is yes, go ahead, do it. Sometimes you will have problems. Decisions will always not be correct. Nobody in this world has made all decisions correct. So you will be wrong, but there should be some justification. You should be able to, say, yeah, these are the reasons why I went for this. And then if something goes wrong, then
I think that is about ERCP in acute pancreatitis is that if the patient is obstructed or if the obstruction is getting worse, you go in and do it. If the LFTs are settling, the patient is settling, you wait for a few weeks and do it effectively. If you need to do it acutely, then you should assess your own skill as well. Because ERCP in acute pancreatitis is always challenging. It's a very challenging procedure. The anatomy is distorting, the papilla might not be in the right position, it might be stretched out. So if you feel it's necessary to do it, then it's always best to refer to a colleague who is good at it.
So what I have experienced, I don't know you guys, is that in acute pancreatitis, where ERCP is indicated, it's black and white. Where it's indicated, it's better to be done earlier. Because as you give it time, edema sets in the duodenal wall, and as the duodenal wall becomes edematous, it becomes like Makar is saying, it becomes more and more difficult. So if I'm going to do an ERCP in acute pancreatitis setting, then I want to do it straight away, preferably if it is indicated. Otherwise, obviously it's not. If you can wait for a few days, then probably you don't need to do that, right?
So there was a question here.
There is a discussion of time interval between low ERCP and between course. Is there 2 to 3 days difference? Or
It depends on clinical. Just for example, if I have a patient after 3 days the LFT is normal. और ये सेकंड वाला पेशेंट जो है अगर LFT आपने जो है वो फ्राइडे को कराए हैं और आपकी वो मंडे की लिस्ट पे आ गया है और आपको लग रहा है कि पेशेंट क्लिनिकली जो है वो थोड़ा सा बेहतर
Sorry.
Oh, this is
So apologies.
Sorry,
Yeah.
sorry. Go ahead.
Ji.
The previous patient, if patient got acute pancreatitis even before ERCP, and is it justified to go for ERCP?
Which one, sorry? Which one?
In this patient,
No, he's talking about the previous patient. If a patient presented with pancreatitis, would you go for ERCP?
cholangitis you are.
If you
Second patient, cholangitis of plus.
ये है ना ERCP 9 mm वाला ये लगा हुआ है.
Yes, post ERCP pancreatitis.
No, you need to have,
Before ERCP under pancreatitis.
लेकिन अगर cholangitis हो
yes, correct. You get cholangitis and pancreatitis as well, then yes. But still, I think in these days, again, even you can get some imaging, cross-sectional imaging first, right? So, you can
So
still
the
get
big problem here is, and again, you're saying cholangitis and pancreatitis, right? Pancreatitis, acute pancreatitis, how do you differentiate just based on LFT?
No, I think clinical.
So to me, in this patient, if we had another imaging, which is certain, another imaging shows a stone in the CBD, we'd go in and do it if they've
You
got
need
that.
some imaging. That's
If you don't have, then you know that this could be a sequel of acute pancreatitis, so you sit back and treat the patient.
even if it's pancreatitis, but if the stone has passed out, it's just wait.
Hello,
So you need some
hello,
imaging. But
hello.
There's a bottom line. Two things we've learned now. Patient is well, don't rush to the ERCP. Second, always get another imaging cross-section.
I think you call, if I may add what Professor Niaz earlier said, you either go in early or you want to leave it because you don't want to go in as you, Dr. Makar earlier said, because you don't want that edema to set in and make your job difficult. So you would want to kind of either do it as early as possible or leave it if you can, if your patient is stable enough, and make sure you've got some cross-section imaging. Okay, so moving on to the next one, is that okay? So this is a 71-year-old lady who has a reasonable performance status, and she's come in with a painless jaundice. So remember, painless, painful for us. The bilirubin is 20, ALK phos is 351, ALT not too bad, albumin is probably low, possibly because of what state patient is in, and they've had an ultrasound scan which reported significant intrahepatic duct dilatation, and there are some gallstones, I assume, in the gallbladder. And you are there, and you are wetting the referral. So hands up, good, I like it. So you worried about this patient, okay? So what would you like to do next? Okay, good. So excellent. So you want some further cross-section imaging. Do we all agree with that? So, and it is incredibly important. Remember, the history is not always clear, especially in the elderly or the frail patients. Sometimes we see it, they will not give you a very clear history of pain or painless, and sometimes you want to sort of rush in with your ERCP. And we've seen patients who have presented with a resectable malignancy, or the patient was subjected to an ERCP, which resulted in a post-ERCP pancreatitis, that then delayed their definitive treatment, and in some cases, unfortunately, by the time they had a further imaging, scans, the malignancy had become unresectable. So cross-section imaging, so
I just add something there. So if you guys can,
Hello.
if the CT can't be done immediately,
Hello.
you get a CT scan after 3 days, and I change the scenario that the CRP is 200, what would you do? Would you wait till you get the CT after 3 days, or would you go for ERCP? Because even if you look at this, she's 71, her albumin is only 21. So she's already got a systemic illness going on, which is causing her to have a low albumin. So I'm sure if you do a CRP at this point, it might be quite high anyway.
Does she have a raised TLC?
yeah. So another observation, again, as I said, may be relevant to our practice, but patients who have an obstructed duct because of a tumor malignancy, you usually do not see raised inflammatory markers. So these patients can wait. So we do get pushed from our colleagues around region and within the hospital as well, where we would sometimes want to have a biliary decompression, ERCP, as soon as possible. But maybe, correct me if I'm wrong, patients who have an obstructed system because of a malignancy generally do not tend to get raised inflammatory marker or an infection or inflammation. Obviously, this clinical scenario is always dynamic, things may change, so as Shaneen said, so you may have to consider earlier biliary decompression, i.e. ERCP in another form. But therefore, you've got to be careful, and I think the message is clear here that we want to do a CT scan. So patient had a CT, which reported possible cancer in the head of the pancreas. There was a tissue abutting SMA. Patient had an ERCP, which, so there was a CBD stricture, distal CBD stricture. Patient had brushings, fully covered metal stent was inserted. Any comments at this stage?
Why fully covered? Why?
No, I think in the UK setting, normally these patients will come to accident emergency first, and then they will just book a CT scan. And then if that CT scan was not a pancreatic protocol, so initial CT had said probably this was unresectable, but they came to the ERCP, we didn't have an NDT discussion, so the fully covered metal stent was placed in at the time because we didn't know what the final outcome would be.
So you stopped placing plastic stents. What's the advantage of putting a fully covered metal stent?
So our setting.
Not even, it's not even. I don't agree that it's easy. I think that's a. But there's a lot of money going in. I think
there is a culture there.
No, culture अपनी जगह but has to be justified. In a patient like this, I'm not aware of any study that would show that fully covered metal stent would be better than plastic.
That's true, but
the fact that I'm being an advocate here is because we put a plastic stent here and I put my money on it that nobody can prove for now that it's what we are doing is not right.
I think
what they are doing is not wrong, but what we are doing is also not.
I think there was some US study which showed that it doesn't make any difference whether you put a plastic stent or
Hello.
Second question
Hello.
I wanted to ask was because this is again relative
Hello.
to the system. We don't have fully covered metal stents available easily, and they're even more expensive.
Hello.
So what is the disadvantage? Even if for temporary relief we are कर रहे हो, तो put a partially covered stent you can remove.
आ रही है
Almost all
दूसरा वाला भी चेक करेगा माइक
partially covered stents can be removed. You're looking at surgery here not more than 4 weeks, I assume, even in UK. Our patients are
Hello.
but I don't know.
Hello.
Now again, in UK, in some of the centers, these patients will go straight for surgery. They don't need even put a
what is the waiting for surgery? That's what
for this, of course, there's some centers have got what's called the fast track service.
So that will happen in 2 years.
Yes.
in the few days, 48 hours.
48 hours.
And again, depending on the surgeons.
So in which case that's fine. You don't put a stent in because 20 bilirubin, if your surgeons are okay with that, 20 bilirubin, fine. Some of my surgeons who would refer patients would say, no, I'm not happy operating at 20. So you need to bring it out, in which case you stent whichever stent you do. And the point is that you need to drain this. If your surgeon says you need to drain it, and if the surgeon says I'm happy to operate, then let them take the surgery.
So it's again your team. How's your team and what's your time? Surgeons want.
So I hope this discussion sort of makes you all aware that there isn't the different ways you can skin the cats, different ways of doing it. And again, depends. Likewise, the same principle applies even with a patient with stone disease or malignant biliary obstruction. Do you really need to do an ERCP? Can you ask your surgeons? Can they fix the problem for you? It's not you who have to do it. So again, the same principle would apply here. There's a concept of hot cholecystectomy. As Tisha said, there's a concept of hot Whipple. Our surgeons have done cases in the 5 days as well. But depends obviously in 5 days post-presentation.
I think the other thing is that all our ERCP goes to an MDT. And we have 2 MDTs, one for benign ERCP, the other for malignant. So ERCP is something which is not taken lightly. It has to be unavailable emergency.
Now, so if I change the scenario a little, just a teeny weeny bit, say,
Sorry, it wasn't for that.
so assume your patient has imaging reporting that this looks like either a locally advanced or metastatic cancer. And again, the patient remains the same with the same level of jaundice. And there's a possibility of either having a palliative chemo or maybe a neoadjuvant chemo. Okay. would you still be okay in going straight for biliary decompression with ERCP and stenting? Any thoughts? Any thoughts? Anybody would want to do anything differently? So this, remember, when you see something, you see a patient who's got a jaundice mass, autoimmune hepatitis, autoimmune pancreatitis, no, lots of things, okay? Malignancy, confirmed malignancy, not a confirmed malignancy?
Not the age of
No, correct, it's not. So what I'm trying to allude here is that in some patients, you would want a tissue diagnosis before you decompress the system. Because stenting, there is again a data out there, stenting can then make your life challenging if you then have to come back and do an eosinophilic biopsies. So you just have to think about it. Again, the point, pick up a phone and call someone. If you can refer.
Share the reference.
So,
that's not our experience.
So there's a study from Newcastle where they looked at their patients who've had straight to ERCP and patients who actually were either neoadjuvant candidate or palliative chemo. And the conclusion was that actually stenting without tissue diagnosis actually reduced their yield of tissue diagnosis later on. And the conclusion there was if somebody has a mass, I think in this case we don't have the size of the mass, but if it's more than 3 to 4 centimeters, so so what we use in our practice, if the mass is above 2.53 centimeters, then we do not worry and would consider decompression. However, if it's a small mass or patients where there's no mass, so these are specifically those where there's no defined mass on CT or smaller, we wouldn't want to go and stay doing ERCP without taking a tissue diagnosis.
But I think what we are doing is again from the patient's point of view, we are putting all these patients in one single session. They all had years less
That's I wanted to know is because we have that thing as well, but that's not available everywhere.
Everywhere, that's the problem.
Correct.
That's the problem. But I just wanted to know why that would be. In a smaller mass, maybe yes, but not where you can see a mass, you should have a
Absolutely.
problem.
Absolutely. No.
It'd be nice to look at that.
Sorry.
special study की बात कर रहे हो अभी was it with the plastic stent or with the metallic stent?
So that's a very good question. That's another good question. So if it's a cholangio stricture, cholangio is again mass forming cholangios which do not form mass. So this study was mostly for the metal stents. So metal makes the life difficult. And again, if we find ourselves in a situation where we really think we may not get the tissue with the brushing, I know again the yield is different. So plastics are okay.
So what is the rationale for UK going to metallic stent for cases like this? What's the rationale?
No,
no, I'm just trying to see why would you do something more expensive when you know that it's not as effective?
Yeah, I think it started from the time when there was a study was that showed about increased infection with the
that was the Dutch
study.
Yes. So
that was what changed.
लिमिटेड में हम काम करते हैं काफी कई दफा ऐसा होता है
But it might still work.
लिख के देना पड़ता है and most of the patients हमारे पास public sector में ऐसे देते हो that
I think Dr. Saab
right point what you said.
Absolutely. No, you have to use your pragmatism. And I think as Anil said, you don't have to. Why would you have to spend
My problem here is that, tomorrow when the guidelines are made, they will be based on Newcastle study, which doesn't apply to 2/3 of the world.
Correct.
So the guidelines should take into account, if you're going to make an international guideline, then it should take into account what is evidence-based. My question is not based on there is no evidence to support what is being done. But there is one evidence that I'm sure is there, and that's cost. This is all industry-driven. And a lot of things that we are doing are industry-driven.
True.
So hence we are providing free service here. And putting a fully covered metal stent or discussing lamps is actually much easier.
Absolutely. No, I think you have to use it.
I would be able to do 10 patients in that cost. In one lamp, I will do 10 cases.
Absolutely.
So what should I do? 10 and 9 more cases of that. So, when you need to understand. I don't want you guys going from here thinking, what? These guys are doing fully covered metal stent, so that is the way forward. That I'm sorry,
No, that's a very good point.
In fact, one of the VSG last president's famous statement was, guidelines are not tram lines. You don't have to kind of stick to them. You have to take those guidelines and apply it to your practice. So important. Are we okay? Still okay with time-wise?
We are.
Okay, so let's change the scenario a bit. Now, this is a pregnant lady. She's 20 weeks, so second trimester. Comes in with cholangitis. She's not well. She looks like septic and had an ultrasound scan which reports there's a CBD calculus in a dilated duct. What are we going to do?
Yes.
Okay, so somebody said ERCP. Do we all agree? Are we all going to proceed? Let's come again.
Hemodynamics needs to be addressed when for
But if I get us, definitely would have to get us a obstruction relief.
Okay, so I think what I hear is most understandably, acting as your patient's best advocate, you think she's not well, she's got a stone, and we wish to proceed and do an ERCP. Any special consideration, I think somebody alluded to earlier on.
I have performed one USP in pregnant and basically applied with that.
So important thing here is this 20 weeks. So that gives me a little bit of breathing space. If the same thing was at 8 weeks, or within 12 weeks, I would be more worried. So that's one thing. So patient point of view, I think that's important. But patient point of view, the other thing that's important is that the patient's not only cholangitic, but she's hypotensive. So she's septic shock.
Yes.
Okay. So you have limited time here for the baby and the mother, especially mother here. Priority is mother always. But from the patient's point of view, you are asking how do you protect? That's when you come to the leg covering and you cover as much. You don't screen as try and avoid screening as much as you can. There are different ways. I'm sure we'll talk about it. But ये जो आप covering की बात कर रहे हैं तो उस वक्त होगा जब आपने ERCP शुरू कर दी. What are the things that would take you to ERCP or not take you to ERCP? Do you have an option to do something else? That's what I think is the point.
Yeah, so again, remember, outside the box. So yes, that's what we've been doing all along, rightly or wrongly. Can we get it better? Can we improve it further? 2 lives, mother, baby, okay? Septic, I think we all probably agree that yes, at that stage, she needs to have a biliary decompression. But is our only option is go straight for
PTBD can be considered in these cases?
So we want to do a percutaneous approach. Now I have a bit of a skewed opinion about PTC in general. We've been trying very hard not to let our IR colleagues, they're brilliant, they're absolutely brilliant. And what they've been providing an exceptional service for a number of years. So our view is we're trying to move away from PTC as best as we can, in general. Now, this is a special situation. And the problem with the PT, BD, or PTC is the morbidity that comes with it. And I think that plays a major role in our decision making. But is it best for the patient? Is it something that we can offer? I personally wouldn't consider it. But I don't know if anybody else will have
If you don't have the facility to do ERCP in this patient, then your only savior here would be you put a catheter. Morbidity is important, but here we are looking at a serious mortality. Not 1 but 2. So if you don't have the facility, putting in a catheter and letting it drain, you actually drain the thing you need to do is drain the biliary system, correct? So you look at 2 options you have here. You either do, because surgical option in a patient who's he's a hypotensive, you need to wait and see if they become surgically fit. Currently, to me, this patient is almost difficult to even fit in for an ERCP, but in this current situation, with hypotension and everything else, you stabilize the patient, put a catheter, drain it, and then you buy time. And then definitively you can go in and do an ERCP later on or whatever new facilities. That's one.
No, I think so that's exuding his experience that again you have to work with the
So you have to
environment
think
that
out
we
of the box here. You have to think with what you have.
Is that
there to save the patient?
Patients who are septic shock, especially on ITU or INEX house, it's always best to do them under GA because then you have the support of the NSS. Because if you are doing it on your own, you only want your ERCP endoscopy nurses or techs. You don't have enough support for a more dynamically unstable patient. So yes, you would consider maximum support to low patient like this with septic.
But we got a surgeon as well. Is somebody can you operate on something like this?
Sorry,
on this one.
Is a 20 weeks a pregnant patient who's cholecystitis with a dilated bile duct, quite significant dilated bile duct.
Septic shock.
Septic shock. Is the surgery an option
we would prefer the gastroenterologist to clear the duct for us. Yeah.
And again, that's what you need to have a discussion with surgeons as well, because our surgeon will be happy to go straight for the surgery as well, even in the pregnant patient. If they've got a dilated duct, they're happy. This patient, again, in the sense that she's got still another 16 weeks to go for pregnancy.
Very interesting.
If you leave this gallbladder in, what if she?
I thought you were talking about before the surgery.
No, I
because
think
she's in cholangitis, she
correct.
does need an ERCP, doesn't she?
No, but our surgeons might be happy. I'm just hypothetically, depending on the surgical expertise, what they've got, they are happy to go with cholecystectomy and then bile exploration at the same time.
The problem with this particular case in this scenario is that you have no data to support one or the other. Because this is not a scenario that you face very regularly. So you would, whatever you do with your expertise, available facilities, you need to drain that system.
Do you have any experience of your surgeons going in like such patients?
And that's what he said.
That's what we're discussing.
Have you seen your surgeons?
They've gone and done it, yes. They've gone and done it.
You've got one surgeon who will do it.
But that kind of facility is very low, very less.
In such a patient who's not stable, going for 2 procedures, when you have one minimally invasive option available, would be preferable to go for a minimally invasive procedure, see how she does, is she out of septic shock or not, because subjecting her to a double insert, because ERCP compared to surgery is considered to be minimally invasive and less associated with less problems. So it would be better to go for a minimally invasive
Because
such a
you're
patient,
talking here of-
give them a window to improve, and then you can decide whether you
That's what I mean, let's put it this way. If it was my daughter, there's no surgeon coming close to her. I'm sorry. No matter how good the surgeon in the world is, I would take the best guy in ERCP, whoever knows how to do it. I should put a stent in, or honestly, I would have no problem while she's hypotensive and being sick. Put a PTC which takes 2 minutes, doesn't require any anesthesia, nothing. Just put it, drain the thing, stabilize the patient, and then do surgery or ERCP or whatever you want to. Get her out of this mess is what we are interested in.
Be as safe as possible.
That's what but I'm saying
this is for discussion.
Yeah, this is pure.
Because my surgeon was also an ERCP, so an excellent gallbladder surgeon who can also do bile duct exploration. He says, I've killed more patients with ERCP than...
Because he's probably not that good, I'm sorry. That I know. I'm sorry. Anisha, you have to take a stand.
No, what I mean to say is that it is overall, I'm sure, I think just to say, most of you've done for several years, you would have had deaths with ERCP for several years, right? So he is saying that he's so good, his cholecystectomy rate is not killed any patient, but with ERCP he's had a couple of deaths. That's what he meant to say is that, just to highlight, ERCP is much straightforward.
To be fair, if you put CBD stone extraction, okay, standard ERCP, done by a similar quality ERCP, the rates are not going to be different. We are talking about this is one of the problems. When you take ERCP complications, you take ERCP complications as a whole. ERCP complications are different in people who've got strictures, who've got mass, who've got so there are different categories. Whereas what we do is as a procedure, so it's like me saying biliary surgery has mortality of whatever percent, put cholangiocarcinoma there, put pancreatic cancer, Whipple's and Lampoli all put together. That I think is what we are doing with ERCP.
Yes.
So ERCP needs to be separated. When you're talking about benign cases, it should be
separate. We're talking about malignant cases or serious patients.
That's a very valid.
That I think is putting a lot of bad,
I think the other thing to remember is that the danger of radiation is a bit overstated. It does not require protection most of the time.
Exactly.
Because nowadays with digital imaging, very little radiation goes to the baby.
And your thought about saying that more lead, in fact now the thought is that in fact you don't do any extra. In fact you do more scattering.
Yes.
If you put extra lead. So if they're pregnant patients, you don't do anything different from what you're doing for other patients. Because if you look at the amount of radiation we do with ERCP, is becoming less and less.
If you the newer system.
Yeah, if
you're using the 25-year-old system, then it's
correct. Then it's different. If the patient needs an ERCP, they need it.
The other thing is when when you're doing ERCP in pregnant lady, our aim is not to actually do anything. I would actually practically go in and there's a single stone or there's just a stent that needs to be placed. I'll put in a cannula, aspirate, I've got my bile or whatever, I'll put a stent literally without anything and come up if I have to. And just a spot film just to see my wire is in the CPD.
Now this is what
not in the cystic.
This is what we do as well, but this was all for discussion, saying that there is not one way of doing it.
Absolutely.
But
so you may want to look at, there's a nice paper called Time to Take Leads Off. Sorry, Yasser.
I just wanted to second your point about keeping the others away from this patient. We've been trying really hard. So as the expertise for the RCP increases, so what I believe is that all these percutaneous procedures, they are brutal. And not just for a patient this young, and I would beg to disagree with that. So we've had 5 cases of ERCP pregnancy, and so we had a good time discussing with our gynecological colleagues and the surgery colleagues. And as Dr. Srisha said, that a surgeon might be interested in operating on this, but ours were not. So what we ended up doing, we did 5 ERCP in all of those patients, and 2 patients were treated without ERCP, conservative. Unfortunately, 4 of those people who had cholangitis, 2 ended up with an abortion. One was at 12 weeks and other was at, if I'm not mistaken, it was around 16 weeks. So the paradox over here is, none of the patients developed pancreatitis. So the paradox what I wanted to ask was this a sequelae of an ERCP or the cholangitis itself?
$1 million question.
Absolutely. I think the point here is that you first in the lectures, people with a wealth of experience, there are options that you can possibly patients, which is really
one thing becomes very clear. Look at what is available in your setup, what you are best at, and then give that to your patient. Don't try and do something that their surgeons can do because that particular surgeon is fantastic and he's delivering, and that may be right for their scenario. But if our surgeon is not, or if our ERCP is not that good, I wouldn't touch a pregnant lady. The better thing to do is not to touch her than to try and see if you've done whatever number of cases, but you're not comfortable, and you actually kill that patient just because you're doing this procedure.
So just in the interest of time, 2 quick questions.
So हमने अपने कुछ वो डाले complications add की हैं कि मैंने कोई निकाले नहीं because if there wasn't enough time to tell him कि हमने क्या editing की.
Then you're fine to at least talk to patients.
Dr. Shisha को भी बता दिया था.
No, we have done it in first trimester as well. There are 8-week patient. You can still do it with.
If you have a patient who is like this in 8 weeks or 10 weeks or 12 weeks or whatever week, you're going to try and save the mother. But I was saying if you have elective time, in this case it was 20 weeks, so they've given us, when you're looking at patient, you look at different things, and in pregnant women you want to see if it's elective, you can delay it.
But we had a precious pregnancy because she had a miscarriage, the first one. And this was the second pregnancy, very precious for the parents. And it was 8 weeks. So what we did was, we did EUS beforehand to see exactly where the stone was. The stone was just at the lower end of the duct, one single stone. So we know exactly where the stone is. And then you just one cannulate, aspirate, sphincterotomy, put a balloon in, you don't even have to put any contrast. Or sorry, you don't have to do any fluoroscopy as well. So even if you have to do one little bit of a contrast, sorry, and fluoroscopy, nothing's going to happen. That's very
And now we can avoid that even more if you want to with the spyglass. I mean, you can put
So
a
if we can park those questions for now, I'm so sorry, just in the interest of time. Okay, we'll come back to it. Okay, we'll have ample opportunity to ask.
A lot of your questions will be discussed during the cases as well, remember. So a lot of things will be discussed as we start the cases.
No, so now this way we'll just discuss some fluoroscopy images. So again, we'll put a few people in the spot. So up to just anybody just just come say what you see here. What you see here doesn't have to be, you don't have to come to a diagnosis. Just say what you see. Okay, it's here, yeah, what position is it? Hockey stick, is that what you say?
Short scope or long scope?
Short scope, yeah, long short scope. Okay. Out can they say what are you seeing? What else? Dilated system, yes. Excellent. And intrahepatic dilated, okay. And what else you can see? Wire. You can see a wire? Wire, okay. Passing through, what do you say? Sorry? Why do you say it's cystic? Right system, okay. So, yeah, you're right. What is this then? CBD. So, okay, you got all of it. So, what's happening here? What's the indication for ERCP?
So, what's the position of the patient? Any issues? Normally, what position do you do ERCP in? You think the patient is prone?
Why are you saying that's not the way
I'm just saying because the way you have taken the picture, I was just wondering whether your patient is in left lateral position or actually patient is completely open because the whole system is not open. That's why I was asking you. Maybe you've just gone down to an area, but I just wanted to raise this issue that whether when you're doing patients in left lateral, your choreographic pictures will be appearing different. And when you're doing patients in prone, they will be different. Supine and prone are almost the same. So you want to open your systems, you want to see the intrahepatic system, they have to be flat, whether they're on the back. Ideally, spine, they say supine position is even better than prone, but I don't do supine, so I don't know. But prone position opens up your intrahepatic system much better versus the left lateral.
GA patients. Under GA patient, you can do supine because the area is protected and you get a very easy answer.
So that's away from what you were trying to say.
So why we do the ERCP in this complete cutoff? Where is the cutoff? Hilar. So why does it anatomy looks a bit odd?
The right system is
okay, so there is a stricture, yeah? And this was a post-transplant stricture, and that was the reason why the ERCP was done here. And so this was a primary ERCP, so we put a plastic stent in, and then normally if you put a plastic stent in, what's your next step? And the LFS got better, patient got better. With post-transplant, what is the next step once you have put a stent in? Okay, repeat ERCP, when do you get the patient back? 8 weeks. Sorry? 8 weeks. Okay, 8 weeks or 3 months. So this patient came in 3 months later. And my experienced fellow started the ERCP, and I told him it's a simple, straightforward ERCP, just have to take the stent out, and then just put a balloon in and reassess. The structure is gone. So, but in ERCP, there's nothing called simple ERCP, right? So we know that it makes you humble every time you think you're doing well, and it puts you back on the ground. So he did an ERCP. And this was the position of the scope, and the wire went into where is the wire? This is a repeat ERCP. Where is the wire going? Is it a bile duct or a CPU?
crossing the stone or
Sorry?
Don't worry.
CBD? PD. Okay, anybody thinks this is CBD? CBD direction? So why you think CBD?
Because the scope is this side and it is crossing the scope. It is not crossing scope.
Direction.
Spine.
Pancreatic direction.
Pancreatic, why do you say it's pancreatic direction?
Because it is crosses the.
Okay, so I think, what is the position, what's the scope? Is it a short scope position?
No.
Is it a long scope?
Ultra short.
Ultra short.
All the way forward.
Yeah, so if you look at the previous one, this is a hawkish technique. So the reason why our fellow got confused was that it was in ultra short position, and then just because the wire went in this direction, he thought it was in the CBD. And he thought the wire went till here, and he thought it was, when it was pushing it, he thought the structure was still there. Because he thought the structure was still there, and he couldn't push the wire in, he pushed the wire a bit more, and then pushed the contrast in. So what happened when he pushed the contrast in and pushed the wire in? So it perforated this PD and now extravasation of contrast, PD, and patient died. So the learning point here is that so never push. If there's something there not going in, never push.
So we say that in endoscopy, in our courses, we say you should not use the word push. You know the difference between push and advancing. You advance till you find an obstruction. Pushing is against resistance. An endoscopy, whether you're putting the scope in or putting wires or whatever, if you have resistance if you had the wire in your system, right? If you go back to the previous like once you put the wire beyond the stricture, then you can, because you're now advancing over a wire. So you're not going to go here and there and create what happened here. You understand? What his point is that you should not push. Not only in ERCP, in simple gastroscopy where you will not have complications of perforation or extravasation if you don't push.
The same thing is when you're doing intubation as well.
Yeah, exactly.
When you're intubation, so if you're having difficulty, don't push.
For colonoscopy, you'll never have perforation if you don't push.
So what do you do in esophagus if you're having difficulty in intubation in the ERCP? What will you do? Gastroscope. So you have a gastroscope, next you get a gastroscope, have a look down. So no pushing. That's the message which I want. Then he called me and said, I don't know what's happening. He couldn't understand the anatomy.
One thing I want to understand is that, and I'm myself trying to figure out, you have duct going like this.
Correct.
Then you have a duct going like this.
Yes.
Right? No, this is what I don't understand, that what is this ductal system? What is this?
I don't know about this one, but again, I think this is a genuine.
Yeah, that I understand. This is fine. And it seems to me that this is what was confusing me. You see this goes like this, and this pancreas, right? But then you have this linear thing which is kind of, in a fixed space rather than spreading like this. That's why I was trying to think, what the hell is that?
And that's the important thing. See, when somebody is an expert is trying to understand what is happening, because fluoroscopy is a 2D image. So you still don't know exactly what's kind of happening. So you can't completely rely on it. So you have to be very careful.
So this case is fantastic. I mean, this picture is so good. It tells you your scope position in ERCP is one of the most critical, the most critical.
Where is his stand?
Positioning.
Stand has it moved already?
No, he removed the stand and then went in again. So again, another point. The fact that you've gone in before doesn't mean you will not go into the pancreas. The fact you've done a big sphincterotomy doesn't mean that you will big or adequate, whatever you want to use it. Doesn't mean you will not go into that. And one of the things that has been done, if I can use this opportunity, is that you go into the pancreatic duct thinking you're in the CBD, you inflate the balloon to 1.2 centimeter, trying to take the stone out, being very confident, oh, I'm there, you're okay, inflate the balloon, suddenly you realize, oh, it's the back side. It's too late. You actually mess the patient up. I've seen one major complication because of sphincteroplasty done to the back side.
So I was in the same room, but because he was already ready to be signed off, I was on my computer looking at it. And I said, I don't know what's happening. And he had already injected the contrast. Then he immediately took over and then changed the position. I can see the patient did not have a stricture. The patient's stricture is completely resolved. Now got the short screw position, went in, and the stricture, patient's completely well, and the patient died. So I think the reality of ERCP, I think that's the reason why we
go and put a pancreatic stent.
In this patient, we didn't put a pancreatic stent, but you can see the contrast.
Yeah,
but as soon as he came into the recovery, within 2 years, his systemic inflammatory response, he deteriorated rapidly, went to the surgical assessment unit, from there to the ITU within 24 hours and died.
This is why they have been emphasizing your experience, you're in good centers, you've got everything available, yet ERCP kills. That's the message that should be very clear. So you think about it, don't, hamare setup mein, I'm just taking that opportunity because accountability nahi, especially in the public sector. You can use patients the way you want to, and unfortunately they don't complain, or there is no system, and you can get away with it. But remember, you will be questioned. It will come back to you. In this world or the hereafter, I don't know, but it will.
Because in one of the cases, one of the fatalities of ERCP, or one of the principal investigators with another colleague who was a consultant in ECT. So we were going through the whole details of the complications that occurred and everything. And he remarked to me at the end, he said, I wasn't aware that ERCP is as risky a procedure as open cardiac surgery, but it doesn't get the same respect. Which I think, on reflection, was a very important point he made. Because he was an anesthetist, he wasn't an ERCPist. We look at it from a different perspective, but he was looking at it from a more objective perspective. So I think that was a very important comment that he made, which I remember to this day that I've taken lesson from it. That it is something which we should always treat with great respect.
And just important for all these objectives of the care, most important of all this, there are more of cannulation here, but most important of all is patient selection. Okay, that is the most key here, and that is what we wanted to emphasize.
क्या ये अच्छा नहीं होता कि हम इसको पहले वायर डालते और फिर स्टैंड उतारते वायर स्टैंड के अंदर alongside
Yes. Which you can screw into the stand. In use of fashion, I used to use that.
No, that is done if you have difficulty. If you perceive difficulty, if you think you'll not be able to put a stent again, then you go through. But nowadays, you see, with all the tools you have, and obviously experience also, generally speaking, you don't use that. That is a technique of bringing the stent over the wire, and then you maintain the wire and then put a stent.
Sir, if you would have done that, my first ERCP was difficult. But the first ERCP, it was in 10 minutes we had done it. Even to the stricture, it went very easily. And so I told my fellow, it was a quick ERCP for me last time. You just have to take the stent out. Okay. That's what I'm trying to say, that you can never downplay an ERCP. Just because as Saad said, first time it went easily doesn't mean that it will be the same next time.
And that is, I'll tell you what happens is that when you've done a lot, the reason why we make mistakes is because we become overconfident. I've done 30 years of experience, so I mean, that's a piece of cake. Every time I've got stuck is when I go in with this mind, I go in and say, 2 minutes mein aa jao, and 2 minutes get. Because, there is some power somewhere, is actually saying, okay, you think you're too smart, let me show you know nothing. So this is what happens with overconfidence in a procedure, जिसमें mortality है ना, even morbidity भी है. I think we should not be dealing with human life, so we need to be very, very nice. Next.
Sir,
सर इसमें स्टेंट के स्पेक्ट्रोटॉमी हुई थी पहले?
Yes, yes.
उसके बावजूद भी पीडी
इसके बावजूद पोजीशन वाज डिफिकल्ट एंड देन ही हैड गॉन इनटू
इसमें एक लेसन ये भी है कि आजकल जो कैलकुलेशन होती है सीबीडी के लिए उसके लिए जो है फ्लोरो पे आपकी जो ERCP स्कोप की पोजीशन सबसे अहम होती है। इसकी ERCP की पोजीशन ही जो है वो पीडी की थी।
Ultra short position थी and then he misinterpreted the way why I was going.
Exactly. How much down the road was this patient post-transplant?
I don't remember now.
Because as the transplant graft increases in size, so the anatomy changes.
Correct.
So probably that was one of the other reasons.
This is also cadaveric, right? This is not
cadaveric.
UK you're talking about. That's why you had that. That's why it got better. So
Okay, we'll show a couple more images before the coffee. Sorry,
The reason for showing these images is that ERCP is not just about cannulating. तो इसका मतलब ये नहीं, although these are interesting images that we want to discuss, लेकिन इसका मतलब ये नहीं है कि बस cannulation हो गई, so that's the end of ERCP. That this is the most important bit of the ERCP. ठीक है? Cannulation is at least a bit less than that. Cannulation तो ठीक है आपने achieve कर ली, but this is where you find out what you have to do. स्ट्रक्चर है, कौन सा स्ट्रक्चर है, वायर कहाँ जा रही है, कहाँ वायर डालनी है, कहाँ नहीं डालनी, दिस इज द मोस्ट इम्पोर्टेंट।
करेक्ट।
ठीक है, तो द रीजन फॉर दैट इज टू डिस्कस दिस इमेजेस। जहाँ आपको लग रहा है, इफ यू फील दैट नो दिस डज नॉट लुक राइट, स्टॉप। नो एज यू नो as somebody did push so if you feel कि यार ये मुझे images for example the पुरानी वाली पिक्चर है, मुझे सही नहीं लग रही थी image, ठीक है? If I feel कि यार मुझे सही नहीं लग रही, so I stop. I don't push, I don't try anything. I reassess. Okay, am I in the right place? Is the position of the patient different? That's why I am feeling it different. Or am I in the wrong place? Or if there is somebody there, I call them, I ask them to look at it, rather than I just go and do it and then end up in complications.
So the next image, your train the trainer delegates to him of your president delegate. Okay, right. So what is the, if you're training a trainee, right? So struggling to cannulate the cannulate, and then the next thing you go and start wearing your gloves and apron as a trainer. What will happen to the trainee when you do that?
We call it the let me see moment.
Huh?
Let me see.
That's when I take up and that's a let me see moment.
Let me see.
Yeah. So you're asking what I do while I'm training?
When you start, if the trainee is doing and he's struggling to cannulate, you don't communicate with him, but you as a trainer start wearing a gloves and apron. What will happen to the trainee's psychology?
That shuts down immediately.
Or what is he wants to?
Let's calculate.
He wants to get in. He wants to get in
Before his thought process stops, he gets rash either, or we have two kinds of training, because I've been training a lot of training. So some of them try to rush it, and some of them just halt.
It's most important before he takes it, I want to cannulate, right? And that's what happens. So, right, he's trying to cannulate. So where do you think is the wire now?
I'm not happy with the scope position.
Okay. What's the direction of the wire? Is it in the, where is the wire? Sorry, wire. Could be CBD.
Could be, but because the scope position is, again, I would re-emphasize, it's not the way I want it to be.
Okay.
So my gut feeling says that it's not there.
Right. So how will you assess that whether it's not in the CBD or not? What can you do?
Last time.
Okay, it's definitely not in PD, right? So definitely,
Yes.
If it's not in PD, if it's not in CPD, where else can it be?
Third stage.
No, cystic.
Cystic, yes. Gallbladder.
Okay, so he's injected some contrast then. What's happening? This.
Third space.
Yeah. So it's just what happens when it's a submucosal space. So you can just change the direction, and you can see that there's much more. The CPD was more in the acute direction, but this was taking more of a. So this know-how was done, but just was to emphasize that when you do something like that, the trainees have a tendency to just rush in. So having that will come to when you come to the trainers later, that communication with the trainee, that when you're asking them to do what you should communicate, will come to that.
The other point, sorry.
Yeah,
the other point here is when you are injecting contrast, don't try and rush कि मुझे 5 ml foreign के foreign ही inject करेंगे ना, because if you are in the wrong space, you know, even if you inject very small amount, you would find out that you are in the wrong space, so that saves you from injecting a lot of contrast in the wrong space.
I think if I can add there, I mean, in our practice, and
इसमें कैथेटर जो है गाइड वायर के साथ ही किया है, और आई थिंक जो है इसने कैथेटर ही पुश किया है, क्योंकि हम लोगों जो इमेज देखते हैं सीबीडी में पहले जो है वायर को देखते हैं, और हमारा जो कैथेटर होता है वो स्टार्ट में होता है, मगर इसका कैथेटर जो है काफी हद तक मेरे ख्याल में आगे
Because he was sure कि वो right side पे है.
you put the catheter over the wire, if your wire goes smoothly, you know you're there.
Yeah.
The discussion, I think it's important to know how much dye should be injected. So again, there will be difference in practice, but one thing is for sure, if you're draining a system which is closed, you've got a stricture, then it's best to inject little dye, and if you think that the best thing is to aspirate some and then inject that much dye. But our practice now is almost completely wire. Right? So we will not inject unless we, in maybe 20% of our patients, we then have to inject, but when we inject a little bit just to see where the stricture or where the way is, and that's all. And then once we've got in, that's when we'll inject and fill the system to ensure that we always drain the blood system. So we've gone off. I know a lot of people have done that. I'm sure. But filling of the system is, because by and large ERCP is no more a diagnostic procedure, right? Yeah. So the images that we see, intrahepatic images, you can see them on MRCP without injecting dye. So we are going to put in a stent. We just need to put in a stent in a place or remove whatever we intend to do. But dye ka khayal rakho. In our setup even more, because we are reusing accessories, because unfortunately our scopes are not that sterilized or clean as they are in the rest of the developed world. So we need to be even more careful. We are introducing infection into a system. So be very careful, please. Use the wire. Once you've gone past, inject properly. Otherwise, use minimally. You can add.
So this issue में wire पहुंची है. They must have used a lot of force there.
Correct.
Normally जब आप calibrate करते हो, मतलब wire pass करते हो, तो you require a minimal amount of it. ये बिल्कुल नहीं होनी चाहिए. और अगर आप experience assessment हो, तो they tell you, क्या मैं experience मतलब resistance है. So you shouldn't force that. That's very important.
But here आपको assistant है, लेकिन हमारे we are single short, we are all short wire system, so we are in control, right? So the trainee was in control, so he pushed it. Yeah.
Oh, jealous.
Because he knew that I was wearing the gloves, and then he pushed it over. Right. So again, short scope, right? Okay. और क्या देख रहे हैं? Okay, where is the wire? Which direction is the wire? Left system. Okay, now you're injecting some contrast. What are you seeing?
Go back to the previous picture.
Yeah.
Look at the wire. Now, do you think that wire is in the system the way it normally goes?
No. On the right side में चला जाता है, ये ओरिजिनल है.
हाँ?
नहीं ये नहीं पूछा मैं आपसे. आप मुझे ये बताइए कि आपके हिसाब से जो ये बेबी वायर है.
Shanil, can we reduce the light a little bit or?
Can we see कि जो वो है, जिसका sphincterotome है, is pushed toward the wall. और ये if I'm imagining things.
Okay, so where do you think is the wire you said? Left system. Or are you worried about something?
Not exactly.
Okay, next I'll show you another next image. We put in some contrast now. What's happening to the contrast? Where is the contrast?
By the way, somebody was saying sphincterotome. This is not a sphincterotome. This is a balloon.
Balloon, yeah. Huh? Where is the leakage? Inside leakage, are you saying that there's a perforation? Where you put it? Yes.
Yes.
Where? How could you have perforated? Where?
This space.
Okay, if there's a perforation, but what would happen to the contrast normally? Exactly. So that's the mistake. It is a localized correction, right? It's all in a localized. If it was a perforation related, the contrast would just explode. It would be very hazy. But why is it localized?
System communicating with system.
Correct, exactly. Yeah. So it's so it's not a. My trainee was getting worried that this is a probably perforated. The reason why I said no, don't worry, it's not perforated because it's in a localized space, as you rightly said. So this patient had cholangitis with also an abscess in the liver. Yes, I can get to that. Yeah. So this patient had a periampullary ampullary diverticulum and had done a sphincterotomy. Again, short scope, right? And then what else you can see? Where's the wire?
In the region of the cystic duct.
Okay, probably wires in the cystic duct. This patient had a small stone in the lower CBD, and then patient comes out of the procedure, stone is out, patient comes out, is in a lot of pain. Is it? Right, so perforation is that you're suspecting. So what I'm trying to emphasize is, can you diagnose perforation on your fluoroscopy? Right, I don't think, we pay a lot of emphasis to fluoroscopy, but it's not very good in a setting to identify perforation at the time. I know there are a lot of thoughts that say that, oh, you can't see this and that, but no, it is your clinical diagnosis which is more important. And when I say it's a periampullary diverticulum, what happens to the anatomy of the ampulla? If it was not in the, if there's no diverticulum, I'll just move this one. If there is no diverticulum, normally the ampulla has got a very anatomy. You'll have a papilla, you'll have an infundibulum. So you know exactly most of the time where is the limit of it, of your cut. Because the infundibulum is very well defined. But if it's an ampullary area, if it's a diverticulum area, the infundibulum is not very well defined. So you don't know exactly how much to cut. So in that setting, what's the safest way to do it? A small cut, and if requiring a sphincteroplasty. So don't hesitate to do an early sphincteroplasty in that setting. And that's the message we learned from cases like this, in the sense that this patient had a perforation at the previous sphincterotomy. And fluoroscopy is not very good at that. If you suspect that there's a little bit of a more cut, even the patient we have a very low threshold if you think to put a fully covered metal stent in if you think it's a perforation. Or when they come to recovery, then CT scan, early CT scan. Fluoroscopy is very unreliable to do that.
Especially when you're talking about these kind of perforations. So large perforations, sometimes you'll see the ear and you obviously become, but sphincterotomy related perforations are not.
So as an ampullary setting, if you're worried, always do a small sphincterotomy and a sphincteroplasty. That's the most safest way to do it.
The thing that happens with that is also, move on, we'll probably cover it.
No.
We cover that.
We'll do one more case? Yeah, one more. Okay, again, scope position. Long. Wire. What is seen? Stricture. Okay. So it's a cholangioCA. Okay, this was a stricture. How do you decide what's the size of the stent you put in? I know we put more of a metal stent in. Plastic stents, you use a lot of plastic stents. How do you decide what is the size of your stent? Okay.
This is a mid-CBD stricture.
Yes.
So again, this is looks like mid-CBD stricture. And for mid-CBD stricture, the 8 centimeter metallic stent is good.
Okay.
And sometimes if the stricture is not very long, I mean it is not covering to the proximal one, so 6 centimeter is also good. But usually 8 centimeter. And in the rule which I know is for the distal CBD 6 centimeter.
Okay.
For mid CBD this is 8 and proximal 10.
So there are different ways people used to measure, various people, but it's actually, is it reliable? No. That's not available. So simple maths, I think, is which is always helpful.
Why do you say it's not reliable? Sorry, I'll discuss this.
Okay, we can discuss this in detail, but it's always either you overestimate it.
You don't have to. The simple principle is what I'm sure he's going to show.
Yeah, so if you're in a short scope position, right? You've got a short scope position as a wire end. If your stricture is below the scope, at the level of scope or below the scope, 6 centimeter always works. If it's above the scope, the stricture, then 8 centimeters, not reaching the hilum, but above 8 centimeters works. But that's the simplest kind of a measurement. So you don't need to do any of those measurements or anything like that. So
उससे सर हम कर सकते हैं कि जो सीढ़ी की जो लेंथ है 4 to 6 सेंटीमीटर उसकी लेंथ होती है और 4 सेंटीमीटर जो है वो CHD की होती है उस बेस पे हम कर सकते हैं अगर मुझे
I think that also varies. Depends on the patients.
ये इतना सिंपल है ना, सिंपल इसमें क्या प्रॉब्लम है? स्कोप के नीचे अगर स्ट्रक्चर है तो पुट 6 सेंटीमीटर, स्कोप के ऊपर अगर स्ट्रक्चर है पुट 8 सेंटीमीटर, हाइलम से ऊपर है पुट 10 or above. If you've got transplant patients, the ones we do, which are all of them are living donors, you need to put a 12 or 15 centimeter. Again, there sometimes the measurement works. That's why I was asking. You need to have, sometimes 12 and 15 के बीच में बड़ा फर्क हो जाता है. 15 becomes too long, and you're not sure about 12. So sometimes, very rarely, that helps. But I was just, we'll discuss that later on. So, but हम क्योंकि metallic views नहीं कर रहे हैं, and that's for metallic stents, by the way, 6, 8, 10. For plastic stents, you can follow the same thing. 7 centimeter for stents, for strictures that are up to the scope, and anything above that you can put a 10 centimeter stent. That's it.
Yeah.
And anything that crosses the island, you put a 12.
स्टैंडर्ड स्कोप पोजीशन की बेस पे हम कह रहे हैं अगर लॉन्ग पोजीशन को फिर
या लॉन्ग स्कोप पोजीशन में भी आप स्कोप को हटा दो, स्ट्रक्चर तो आपको अप्रोक्सीमेट मिल जाता है उस जगह. But once you've got everything in, and almost all patients, you can bring the scope down to, once you've got everything in, with the balloon and everything, you can shorten your scope in almost, majority of the cases eventually.
Spot diagnosis, last one before you go for a coffee. Biliary leak. Okay. Again, what stent you put in this case, how do you manage? We can discuss that during the course of the next 2 days as well. But okay.
उस पूरी सिस्टम की और इसमें
is it necessary आपकी length of the stent, is it necessary to decide what stent? Is it necessary to cross the area where the leak is? Is it?
Yes. Cross the area.
Again, it depends on whether it's high leak or low leak.
Correct, yeah. So it's not always necessary that you cross the area. The main reason why you put the stent.
But this obviously is, to me, it looks like it's a high leak because you've got a lot of, your filling is, I don't know, obviously this is not dynamic, we just shown one picture. जब आप dye डालते हो, अगर आपकी leak आपको पहले नजर आ जाती है before filling of the system, dye going up, then you know this is a high leak. Okay? And there you need to do more than just a sphincterotomy. But for low leaks, a sphincterotomy by and large is sufficient. You don't even have to put stents in. I don't know if you're clear.
Yes.
सर इसमें एक सवाल है कि उसमें बहुत सारे हमारे या पेशेंट रेफर करते हैं सीवीडी इंजरी हो गई है ये सस्पेक्टेड होता है उनको यानी उनका बाइल लीक आ रहा होता है तो इसमें क्या हमें कोई पहले एमआरसीपी को देख लेना चाहिए कि अगर डायरेक्ट ईआरसीपी प्रोसीड करनी है ये थोड़ा सा कंफ्यूजन होता है तो हम
It's a very important, I think it's a very important question. You want to summarize the question?
No, I think he's asking that if you get a bile leak, surgeons are concerned about the bile leak, and they're asking for a ERCP, and so they're asking whether you need further imaging before you do an ERCP. What do you? What's your before ERCP, because the patient post-operative bile leak है.
Would you go straight for ERCP or would you need further imaging? Why would you do an MRCP? So you will be able to understand what you can do for ERCP before doing it, maybe not leave cut off, in which case you say, well, look, you know, although we've got a small, हमने publish की थी ना, that was जो post British में, we've done MRCPs, inflation को we failed, we thought they were complete, we did it in MRCPs, तो हम शुरू में नहीं करते थे. And MRCP में मैं communication में we went back again, and then we went, we managed to actually complete in quite a significant percentage. So I think now we do MRCP anyway. So,
but would you do MRCP before proceeding for ERCP?
you know, it depends. Ideally, if it's available, yes, it helps you a lot because you know it will give me an idea about what you're asking. Aksar, I will tell them that you've already completely dissected it. I don't think it'll be successful. We still would probably go in if we see some communication. Sometimes it's so clear that you know that there is going to be no problem. That way, it's advantageous. But do I need it in every case, and do we do it in every case?
Sir, with the MRCP, and the repetition of fluid connection,
That's the problem.
that's the problem.
Because in leakages, we usually have a collection.
Another problem is obviously the quality of MRCP. We talk about MRCP, we talk about TUS here. It depends on how good you are. If you don't have good MRCP, if you have got a magnet of 0.4, then I'm sorry, your MRCP picture is useless.
Secondly,
By and large.
these patients are very ill and in severe pain. Sometimes they might not even settle down with MRCP.
And plus a lot of people would refuse.
Yes.
I don't want to go into that machine.
So we'll take a tea break.
Mr. Tea break? Five minutes.
Yes.
In this machine, just was interrupted in the machine, all is
I think our set of
Hello, 1, 2, 3. Hello. 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 1, 2, 3.